rate of sickle cell occurrences seems to be reducing due to enlightenment, but it might shock you to realize that a lot of people still don't know what it is or how it comes to be. There are even some very funny myths about it. Welcome to Catholic Faith Forum. I am May, and we'll be discussing sickle cell anemia. When we come back, we'll meet our guest. Stay with us.
Well, for sickle cell, I think it's hereditary. That's from my little research, that's what I got to know, that it's hereditary and it's something that one can inherit from one family or something.
Sickle cell, that's when two spouses, man and woman, they are not having matching genotypes and all of that. I think that should be, yeah. That should be something about, it's about the genotype, not having matching genotypes, and then you're married, SS getting married to SS, red flag, AS getting married to another AS, 50% red flag, 50% safe, so I guess that should be it.
Okay, I really don't know much about that. I need to be very, very clever. But then I just this SS whatever thing, yeah, exactly. I don't know. But only thing I can just say is that parents are to avoid these things. If you know your SS, you shouldn't get married to me that being an SS too. I don't know if he gets it. So you have to look for someone that is AA, like genotype wise, not same genotype with. If you're SS, you shouldn't be looking for someone that is SS or even AS. Is a no-no. So to avoid these things, like the death rate in the country, you should have to stop it. Like, I feel it's more like you're the mother yourself, because you knew this was going to happen, so why go into it in the first place?
Welcome back. You're watching Catholic Faith Forum. I'm May, and today we'll be discussing sickle cell anemia. And I have a guest in the house. His name is Dr. Adewale Daramola. He's a resident doctor in the Department of Family Medicine, Federal Medical Center, Ebute-Metta. You're welcome, doctor.
Thank you very much for having me.
We're so happy to have you here today.
Thank you very much.
Okay.
So pleased to be here too.
So how is it, as a practicing doctor, how is the experience like for you? What do you get to see every day?
Well, to start with, it's actually I would describe it as very debilitating as a condition. And it is something that we don't have much control over, because in developed countries, I mean, sickle cell disease is the least of their worries as far as practicing medicine is concerned. But it is shocking that we still have
a lot of cases
in this part of the world, especially in sub-Saharan Africa.
Okay.
And considering the population of Nigeria.
Yes, constantly increasing.
Yes, and when they say the incidence is between 2 to 4%. You know, 2 to 4% in Nigeria is different from 2 to 4% in Togo. So Nigeria actually carries a lot of the burden of sickle cell disease in sub-Saharan Africa.
Oh, that's really sad.
So at the moment, we have, well, it is tied down to poor education.
Okay.
I mean, educating people about this particular condition. Yes, the bulk of it is tied down to it, because it is not an infectious disease. So you cannot say there is like a vector responsible for it. It is inherited.
True.
So the more people get to know about it, the better it is for the whole country.
That is why we're doing this here today. So I'm really happy we have you here today.
Oh, thank you.
So can you tell us, what is sickle cell anemia?
Well, sickle cell anemia, it's one of the variants of sickle cell disease.
Okay.
Sickle cell disease is like the umbrella that houses all of them. Sickle cell disease is the most common of the subunits under sickle cell disease. It is a disease that is inherited in an autosomal recessive version.
All these big words, please.
I will try to be as I'll try to be as layman as I can.
I understand.
It is inherited one.
Okay.
The inheritance is autosomal recessive. What autosomal recessive means is you need 2 copies of the abnormal genes for you to be said to have the condition.
Okay.
A copy from the father, a copy from the
mother.
That is when you can be said to have sickle cell anemia.
Okay.
And it is basically an abnormality in the shape of the red blood cells, which makes them very non-flexible. So it makes them die earlier than the normal red blood cells. They don't last for the 100 to 120 days that other normal cells last for. So there are other variants of under sickle cell disease, but sickle cell anemia is the most common, and that is the burden we are actually facing in the country
right now
at the moment. Yes.
Okay, so who can be affected by the sickle cell trait?
Well, like I said earlier, it is not an infectious disease. People that can be affected, or people who are at risk,
Yes.
are people, unborn offsprings or unborn individuals of parents who are carriers. What it means is that babies who are not born yet, but potentially going to be birthed by parents who carry a copy of the abnormal genes, are the ones who are at risk.
At risk of
Yes.
getting this.
Of having sickle cell disease. Like I said, it doesn't work this way because you have sickle cell disease and I'm sitting close to you,
Then
and
get
then
it.
I'm going to get it. No. It is determined at
So it's not
conception.
contagious at
It's
all?
not contagious at all.
Okay.
So it is determined at conception. So long as one of the parents
Has the trait.
has a trait, that means the person is potentially going to be a carrier. If both parents
Have
have
the
a
trait.
trait, that means there is a tendency, or there is
The
a
tendencies are
chance
higher.
that the child, their offspring, one or more of their offspring might end up having sickle cell anemia. So that is how it works.
That's really sad. And it can't be helped. Okay, first, let me ask first, how is it diagnosed?
Well, I'm going to divide the diagnosis into two.
Okay.
There is the prenatal genetic screening, and there is the post-delivery screening. The post-delivery screening means the child has been given birth
Born
to,
already, yeah.
or just a normal individual who wants to go for a screening.
And check.
Yes, you take the blood sample, and then it goes through electrophoresis. That is the name of the test that is done to
All
determine.
these big names. But
Well,
we're following, no problem.
The prenatal screening, it is actually, well, I think I have to chip in this now. When two carriers, when they want to get married, me as a medical doctor, well, I won't hide under the umbrella of faith or just believe nothing is going to happen. Well, I would always advise against two carriers marrying each other.
Married.
But then these days, because there is prenatal diagnosis, some people go ahead and they get married. Prenatal diagnosis means after the woman conceives, between 10 to 12 weeks, you can take a sample of the placenta.
Okay, while the baby is still
developing, you can take a sample of the placenta, and then you can test it.
Isn't that risky?
It is actually, well, if you have the right expertise, it is actually not risky. But the danger about this comes when the child ends up being sickle cell or has sickle cell anemia. So what happens? It means the only option is going to be an abortion, most likely.
Which is totally wrong.
So the prenatal diagnosis has made it possible, sort of, for people who decide to go ahead and get married. I mean, two carriers decide to go and get married. It has made it possible for them to determine if the child would have sickle cell anemia before birth. That is they call it the chorionic villus sampling. Then there is another type, amniocentesis. That one is a little more easier than the chorionic villus sampling.
Okay.
There is a fluid in which the baby swims inside the womb. You can take a sample of that fluid.
And you can tell from that?
And you can test for the genotype of that baby. That one, you can do that one later on in pregnancy. I think about close to 20 weeks, which is more dangerous because then abortion at that point might not be a very good option. So those are the...
Well, we know we are not supporting the abortion option because that's definitely not a way out.
Well, there is a difference between sickle cell trait and sickle cell anemia. The trait means because every individual is a copy of the father and the mother.
Okay.
Having a trait means someone has an abnormal gene for one copy of the abnormal gene and a normal gene. That is the trait. It means there is a normal gene, there is an abnormal gene paired together. That person has a trait. The person doesn't have sickle cell anemia. having 2 copies of the abnormal gene means that person has sickle cell anemia. Like I said, it is autosomal recessive. That word recessive means you need 2 abnormal genes for one to be said to have sickle cell anemia. When you have 1 abnormal gene and 1 normal gene, you are said to have a trait because it is autosomal recessive in that you need 2 abnormal genes for you to be said to have. But because the normal gene is available, it suppresses the activities of the abnormal gene. So a trait means 1 normal, 1 abnormal. Sickle cell anemia itself means 2 abnormals. Yes,
so what are some of the dangers a person with sickle cell anemia faces? What are some of the things that they go through?
Well, like I said, it's not too good a condition to have because apart from the standard crisis that they usually have, the most common one that we see in this environment, the vaso-occlusive crisis. What vaso-occlusive? I'm going to explain.
Okay.
What vaso-occlusive means is, like I said earlier, that their red cells, it dies quicker than the normal red cells.
Yeah.
So when they keep dying, it clogs the vessels like a drainage that is blocked. Blood wouldn't be able to flow freely. So the areas of the body beyond this blockage, they don't get enough nutrients. It doesn't get enough oxygen. So they come down with these recurrent pains from time to time. And there is the hemolytic crisis. What hemolytic crisis means is that because a normal red blood cell is supposed to stay for a period of 100 to 120 days, but theirs stays for a shorter period. So they keep hemolyzing, they keep killing these red cells. It keeps dying from time to time. So their PCV is usually low.
What is PCV?
Their packed cell volume, the quantity of red blood cells that they have, it's usually low. So there is need for recurrent transfusion. That's the hemolytic crisis. That's why you see them, because they are breaking down these red blood cells, they have high level of bilirubin. That is why you see the greenish discoloration of their eyes.
Okay.
They have so much bilirubin that the liver is supposed to take care of bilirubin, take it out of the body. But because they are breaking down these cells too rapidly, it overwhelms the liver. That is why some of them is going to manifest as the greenish discoloration of the eyes. And there are other crises which I would not want to really go into. There is the aplastic crisis, there is the sequestration crisis. And aside that, starting from their head to their feet, they are predisposed to having stroke because the blood vessels in the brain, when they get blocked, there are areas of the brain that enough blood will not get into.
Okay.
They can have seizure, their eyes, because of poor blood flow. There's what is called retinopathy, which can, with blindness basically. And then because of poor blood flow to their extremities, there is this non-healing ulcer that they usually come down with. And because of red blood cells that are being clogged in the spleen, there's what they call splenectomy. It means their spleen, because the spleen is an organ in the body that helps fight against infection.
Yes.
Just broadly speaking. Because of recurrent red blood cells being clogged up in this spleen, it can shrink off. And then when you lose the activities of the spleen, it means they're predisposed to having different forms of infections. And then they have poor growth because you need nutrients, you need oxygen in different cells of your body to grow. So they have poor growth. And then their puberty, it's a bit slowed. For the women or for the ladies, they can have issues with menstruation. The men, priapism, sustained penile erection, and then those are the medical issues that they can have. And then you don't have to look at the medical issues alone. There is also the social part to this condition. I mean, the fact that they have this condition, they remain isolated, the discrimination, and then the academic life too, because some of them, we live in the malaria endemic region.
Yes.
I think I have to talk about the precipitants of crisis. Malaria lives with us here. It is a huge precipitant of crisis. And then extremes of weather, this kind of weather condition, when it's been raining since morning.
Extreme cold, and
so
just varying.
They can come down with recurrent crisis. It means their career, if they are career people, recurrent crisis can really make you not have a good focus. And then depression too is something that is very common amongst them too, when you cannot do the things that the rest of your mates are doing because you have a condition. Yeah. So there are both medical and then the social factors too that they can actually face.
That just seems like a whole lot of pain and struggles.
Yeah, because it is so bad that, I mean, I've seen cases of patients who were cursing out their parents, and then, I mean, real curses.
Wow.
What were you thinking, having me?
I've actually experienced that firsthand. A friend of mine, and it was not in my sight.
And looking at the fact that it's a condition that you can't say take paracetamol for like malaria or take anti-malaria for and then it disappears. You know, it is lifelong. So you can really understand the pains of these people.
Can it be treated? Is there a cure for it, or a cure anywhere that can solve this
well,
problem?
these days there is what is called stem cell transplants. It means the bone marrow, that is the source of all these cells in the body. Stem cell transplant means you are transplanting a good bone marrow. You are replacing their bone marrow. It is actually a very tedious procedure, and it is actually, there are dangers associated with it. Okay. And it is not something that is readily available in third world countries like Nigeria. That is why we really don't talk about. It's not even something that they have a grasp on, even in developed.
So they're still experimenting with it technically?
Well, there has been successful stories. I think I heard of a case in one of the teaching hospitals in the, I don't want to start mentioning names of these hospitals, but then it is not something that is easily done. It is not something that is readily available. Okay. You look at the financial part of it, you look at the expertise required to carry out such procedure. So these days, nobody looks at, if it was something that is readily available, I mean, that means all the sickle cell patients would have had it, and then...
By now, yes.
So, sort of, I keep saying there is actually no cure to it. That is the only way to keep it safe at the moment, so that you don't indirectly encourage people who are carriers to just go on getting married and then causing a lot of problems. Okay. And managing it, well, it can be managed to...
How?
A point, there is what is called intelligent parenting when they are still little, when they are still with their parents, because the burden of the treatment actually doesn't lie on the doctors.
It lies on the parents.
It lies on the parents when these children, when they are growing up. You know, the doctor only see for probably a follow-up visit or when the child is having crisis. So it requires intelligent parenting because they are usually placed on a routine drug.
Like every day of their life?
Yes.
Wow.
Because now they are placed on paludrin and anti-malaria, so that they don't come down with malaria. They give them multivitamins and other drugs that can help them form more red blood cells. So when you're staying with a parent who don't care about you taking your routine drugs, you know, there would always be issues.
Definitely.
And then the precipitating factors, extremes of weather, too much heat, excessive cold, you know, strenuous exercise that are demanding, and then of course, good nutrition. So those are contributing. The doctor is not going to live with you in your house. So you, the parents, you have to oversee all these things. And then when they become adults, of course, from the knowledge that they have acquired from their parents and from the doctor, most times they'll be able to manage themselves. And again, there are variants. There are halotypes. There are different types of, there are different halotypes.
Do people know these things?
No, most people don't know. And I think, well, maybe we doctors, we need to do more to educate these people. And we have very little sickle cell centers in the country at the moment. So, but irrespective, I think we really need to educate these people more. There are some people that have sickle cell anemia who look stable. They have less crisis. I mean, these ones, apart from the fact that they are adherent to their medications, the type that they have, the allotype, is the favorable allotype. Okay. The one that there is the Bantu or Central African Republic, there is the Benin. They tag them based on the geographical region where it was first seen. Okay. Like the Central African Republic type, those ones are very, very severe. People with that brand or that kind of sickle cell anemia, I mean, it is more severe than some other types. So that is one factor too that can contribute to severity and then how it is being managed, and then strict adherence to your medication, and then you knowing the precipitating factors and then avoiding them. I mean, those are the things that you really look.
I wish we had all the day to talk about this. There's so much to talk about.
It's actually very broad.
So
but then,
do you have any final words of advice for the viewer?
Well, before I would leave, I think this should be a take-home for everybody. To start with, I am of the opinion, or I belong to that school of thought that believes that two carriers should not be made to marry each other. So there should be premarital counseling. I mean, for young individuals who are probably dating, or courting each other, I think it should be among the first few questions when courtship or any form of relationship is going to start. Because it is better not to have it than to have it and start managing it. Mm-hmm. So I would advise that two carriers should, as much as possible, not be made to marry, irrespective of whatever belief that you have. Because there is this popular myth about, it's the last child. Your first 3 children are going to be normal, and no, it's wrong. To quickly sum it up, what that means is there is nobody that determines the kind of genotype a child is going to have. And it is like you took somebody who is not a professional basketball player, and then you took the person to the basketball court, you blindfolded the person, and then you gave the person the basketball, and you took the person to the extreme of the court, and you kept 3 nets, 4 baskets. Mm. 1 is sickle cell anemia, 2, the carrier state, and then 1 is the normal AA, AS, AA. And then you told the person that throw the ball blindfolded. Whatever you pick is your lot. You cannot rule out the chance that the person can throw that ball 20 times and it enters into the SS basket.
True.
So it means your first 4 children can even be SS. Your first can be SS, the second can be AS, the third can be. So nobody can determine what can possibly happen. There's no formula. It happens randomly, just like how the sex of a child is being determined at concept. Nobody knows. Anything can come out of it. So I think that is my take home for the viewers.
Thank you very much.
You're
there
welcome.
You heard it. Sickle cell anemia is not something that should be joked with. I know it might be difficult to stay away from the person you love to avoid it, but the truth is, in the long run, that's the best way to avoid the pains and complications that come from sickle cell anemia. That will be all for today's show, but before we go, we're going to go for today's episode of Know Your Faith. Stay with us.
Welcome to today's episode of Know Your Faith. My name is Chima, and today we'll be talking about the vessels and linens used by the priests during consecration at Mass. There are a lot of them, but we'll be focusing on the 5 main vessels and the 4 main linens which you usually see at almost every Mass. We start with the vessels. First off is the chalice. The chalice is the royal goblet which holds the wine which becomes the blood of Christ after consecration. Christ is a royal being, so it means that the container containing his blood be royal. Next, we have the paten. The paten is the small little plate which holds the large host. You know that large host which the priest raises up during prayers of consecration? Yes. The paten is used to hold that, and that becomes the body of Christ which we receive at communion. Next, we have the ciborium. The ciborium is the bowl-like structure which holds all the little hosts which have been prayed for, which becomes the body of Christ which is distributed to us during communion. Next, we have the lavabo. The lavabo is the vessel used by the priest when he's washing his hands in preparation for the prayers of consecration. You know, he who must dine with kings must come with clean hands. And lastly, we have the cruets. The cruets are the little holders which hold the water and wine which are mixed into the chalice for prayers of consecration. We'll go over to the linens used by the priests. The first one is the purificator. The purificator is the little white cloth used to clean the chalice after prayers of consecration. The next one is the finger towel. The finger towel is the one that is used to clean the priest's hand after he washes his hands in the lavabo in preparation for prayers of consecration. Then we have the pall. The pall is the stiff, square white cloth which is placed on top of the chalice during prayers of consecration, which the paten is also placed on top. And finally, we have the corporal. The corporal is the cloth which is placed on the altar on which the body and blood of Christ in form of bread and wine are placed during prayers of consecration. Now you know the vessels and linens used by the priest during consecration at Mass. So make sure you call them by their right names. Until we come your way next time, be bold, be Catholic.
Welcome back. It's been enlightening talking about sickle cell anemia. Thank you very much, Doctor, for being with us on the show.
You're welcome. Thank you for having me around.
It was definitely very enlightening.
Thank you.
Thank you so much. For comments, questions, inquiries, feel free to reach us on our social media platforms at CFF on TV. Also, subscribe to our YouTube channel at Dominican Media Presents for this episode and other episodes of the show. Till next time, keep being saints in jeans and shirts. See ya.